And you can go right ahead.
Well, thank you so very much for inviting me again to the Canadian Cancer Survivor Network to talk about colorectal and anal cancer. And thank you so much for everyone who is participating today in the webinar. I have a tendency to speak really quickly, so type in the box if I'm speaking too quickly. My British accent tends to throw many people off. So we'll just get on with it. So welcome. And I think one of the first things to clarify is that I myself am an anal cancer survivor. I was diagnosed with stage 1 squamous cell carcinoma of the anus in 2010. I had surgery and the chemoradiation and have been no evidence of disease from that date. And I am not a doctor, nor am I a nurse. I do have a background in working in pathology, but that was a long time ago. So I'm talking really from the state of a patient advocate. So we're going to start. And as I say, if you have any questions, you can type into the box. So, here. Okay, so what's the things we're going to talk about today? Now, I'm going to try and not totally read off the slides because you guys can see those as well. But I just want to sort of go over, who we are, understanding colorectal and anal cancers with its symptoms, risk factors, and etc., and the Canadian scenario for it, what our treatment options are, possible surgeries, the chemoradiation, and of course the cutting-edge biologics and the immunotherapy, as well as talking about the potential prevention of colorectal and anal carcinoma with screening, lifestyle options, and the huge benefit of peer-to-peer support groups for these particular kinds of cancers. And then after we're done, we'll be doing the question and discussion. But as I say, you can type in the box if you've got anything, and Ali will let me know. So first of all, you'll see two logos at the bottom of the web page that you're seeing. The one with the dragonfly is the Anal Cancer Awareness logo. The other one is for the Colorectal Cancer Canada organization, fabulous organization, Canadian, and they have information for both colorectal and anal cancers. And there are quite a few brilliant international sites now, both obviously for colorectal because it's huge and it's a big problem. So there's lots of resources for that. But for anal cancer, it's now 2019, and I'm very happy to say we've got more and more information online internationally in a multitude of languages, so many people can find them. So basically, the Colorectal Cancer Canada organization is the national non-for-profit organization. You can read on there what it is, and what they're dedicated to is increasing awareness of colorectal cancer, support of patients, advocating for population-based screening, and timely access to effective treatment. Because colorectal is the most predominant GI cancer, that's why you tend to always hear colorectal. We want to say colorectal anal because anal is part of the GI tract. So onwards and upwards we go, and we're going to move on to the next. Anal cancer, a bum rap. So who are we? We're a non-profit organization, and we are based here in Canada, but we provide international support. Online, email, telephone, and what we want to do is really advocate for the promotion and international awareness and education of anal cancer. And I have to say a huge part of that is getting rid of the stigma of saying the word anal. And I think this is one of the most important things that we have to try and achieve. This is why I always say it's just a 4-letter word, just add it. Colorectal, anal. Colorectal, anal. The more you say it, the more use you'll get to saying it, and then the less it becomes a stigma. Reduce the stigma, reduce the embarrassment. That will open up opportunities for patients not to feel so embarrassed about talking about anal cancer, because this anal cancer is on the rise, especially in heterosexual female women, and we need those people who have got all these bum issues to stop hiding at home and get to the doctors. We also provide support for patients and their caregivers, and we're advocating for primary prevention screening and equal and timely access to effective medications to improve patient outcome, because if, as with most diseases, catch it early, good prognosis. Embarrassment, misdiagnosis, you're going in your stage 4. So we've got to get people more in tune with how their bodies are feeling. So when I talk about understanding colorectal and anal cancer, I'm not going to go into huge depth. Neither is it so skimming that you think I'm speaking to 5-year-olds. But we're going to talk about what it is, what the stages are, what the symptoms and risk factors are, and basically what the colorectal anal cancer numbers are in Canada. Now, we use statistics, and the statistics aren't updated frequently. So, it's 2017, things like that, and anal cancer is a rare cancer, so we even get it less updated for that. So what is it? What is colorectal and what is anal cancer? So on the webpage that you're seeing, you've got a picture of the large intestine, and I've arrowed where different things are. So the colorectum, the colon and the rectum, approximately 6 feet, it's known as the large intestine. And its job is to reabsorb water from digested contents, and it serves as a holding chamber for stool or poo, whichever you want to call it. I don't care what you call it, just call it something. And then the anus is the opening at the end of the large intestine through which your stool exits the body, and this includes the anal canal, which is about 4 centimeters in length, and the anus. Now, your anus is, if you went and got a mirror and looked at your bum with a mirror, you would see your anus. You're not seeing the anal canal because that's all inside. So you're seeing the anus. Okay. Obviously, you need a colonoscopy or an anoscopy to see inside the anus and the colorectum. What is colorectal cancer? So when we say that someone has colon and or rectal cancer, we're saying that the cancer is in the colon or in the rectum. So known as cancer of the large intestine or the large bowel. Now, if you go on the Australian and New Zealand sites, they use the word bowel more frequently than we do in North America or in the UK. But I think most people call it large bowel. So, and that's cool. Whatever you call it something, because I want you to be getting to your doctors to say you think you may have a problem somewhere in your bowels. Whatever you do, just go. So most colorectal cancers start in the cells that line the inside of the colon or the rectum. Typically, colorectal carcinomas, typically adenocarcinomas, are slow growing and curable when diagnosed. Colorectal cancer is when it's grown through the entire colon or rectum wall and into nearby tissues or organs, or spread to other places, lungs, liver, whatever. We want to catch people early. And the fact we want to catch you early means that we want you to go to your doctor at the earliest contemplation that there is something wrong. So then we get to what's anal cancer then? What's the big difference between colorectal cancer and anal cancer? So anal cancer is in the area that marks the transition between the rectum and the anal canal, the anal canal itself, and the anus. Now, predominantly, the most common colorectal cancer is called an adenocarcinoma. In anal cancer, yes, you can get adenocarcinoma, but the most predominant one is called squamous cell carcinoma. And as in colon rectum and as in anal, there are a variety of anal cancers, and the prognosis of them is better if caught early, like I've stated. And we'll note that any tumors of the anal margins, that's below the anal verge. So the anal verge is what you can see in a mirror, okay? If you've got it from what you can see in the mirror out onto your buttocks, that's including the perianal and hair-bearing skin. Those are classed as skin tumors. So we're not talking particularly of the skin tumors that can be squamous. We're talking about the squamous carcinomas that are within the anal canal. Stages of colorectal cancer is slightly different from how they stage anal cancer. Do not be fazed by how intricate this can be. Your medical teams are going to explain things to you lovingly, carefully, and if you need diagrams drawing, ask them for diagrams drawn. So colorectal cancer goes stage 1, 2, 3, 4, and it all depends on how the cancer has grown. Has it gone through the wall? Has it affected the nearby lymph nodes? Has it spread to further organs? And then when we get to anal cancer, we're a bit more complicated here because we tend to go from size. So stage 1, less than 2 centimeters. Stage 2A, B is tumors between 2 and 5 and then over 5. And then we've got stage 3A, B. We now have stage 3C just to complicate things. So this is related to its size, as it spread to nearby lymph nodes, or Doesn't matter what size it is, but has it gone through the anal wall and is going through to the vagina, the urethra, or the bladder, but not the lymph nodes? Stage 3, again, we've got stage 3 and different stages of this now. So it all depends on how big it is and what it's affecting. But don't be phased, because your medical team are going to explain it nice and simply to you, and you've not to be afraid. Stage 4 tumors, any size, may have spread to the lymph nodes or nearby organs, and has also spread to distant organs or tissues. Okay, so there's all these different staging mechanisms, but don't be phased out. It's all good. Symptoms of colorectal and anal cancer, a huge amount of overlap for the symptoms of these things, especially for the ultra-low rectal cancers and the anal cancers. And we have to bear in mind symptoms may not be present in the early stages. And if symptoms do appear, they'll vary on the cancer size and location. And I reiterate this time and time again. The most common misdiagnosis in anal and some rectal cancers is the patient and or the primary care physician, GP, thinks that the cancer is just hemorrhoids. Now, hemorrhoids, piles is another word I want you to all get used to saying out loud. Stand in front of the mirror, say hemorrhoids, 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 piles, piles, piles. The more you say it, the less embarrassed you'll be. And I want you to get yourself to your doctor about those hemorrhoids. Because when is a hemorrhoid not a hemorrhoid? When it's anal cancer. And I need you to be vigilant for these things. So all the things you can see on the screens, itching, feeling a lump, weird constipation, abdominal cramps, bloody stools. Blood can be bright red, or it can look blacky, tarry color, depending on where it's bleeding from. So, I want you to start turning around when you've gone to the toilet and done a poo. Your first line of analysis is your own bathroom. You have to realize what it is you're pooing. Is it normal? Do things start to look abnormal? If it starts to look abnormal, don't be embarrassed about it. Get to the doctor. Your doctor is there to help you. I think that's the most important thing. We've got unexplained weight loss, loss of appetite, nausea, vomiting. Gas and bloating is a symptom of many cancers. So get yourself to the doctor and just don't think it's your age or you're stressed or anything like that. Fatigue. Those are the things that we want you to be cognizant of, and just please get help for them. Colorectal cancer risk factors. These are purely risk factors. This does not mean that they definitely have to be there to get colorectal cancer. Age, patient history of polyps, cancer, or inflammatory bowel disease, family history of colorectal cancer, the genetic syndromes, racial ethnic background plays a part, and lifestyle-related risk factors. And I think that when we come to the anal cancer ones, those can be added as well. We've got frequent anal redness, swelling or soreness, inflammatory bowel disease. So if you have hemorrhoids, if you have anal fissures, if you have an anal fistula, or you have a history of any of these things, chronic inflammation over many, many years and decades, we all know that chronic bladder irritation leads to bladder cancer. Okay? So it's no great surprise that chronic irritation can lead to the cells in your body just giving up the ghost and thinking, what on earth is going on? And I'm now going to freak out. So people with lowered immunity, so people living with HIV, people who are on immune suppressant medication, so that's all the organ transplant crew, it's all the people on immunosuppressive drugs, which includes most of the irritable bowel disease crew, so Crohn's, ulcerative colitis, there's a gamut of autoimmune diseases where people are on immune suppressants. And because around 85%, 90% maybe of the anal carcinomas, specifically the squamous cell carcinomas, have been found to have a correlation with the human papilloma virus, if you're immune suppressed, your body's not fighting any of those things as well as maybe it could have done. So human papilloma virus, amazing virus. There's over 200 subspecies of this virus now. I was researching this in the 80s for its cause in cervical carcinoma. And we know the carcinogenic cause in human papilloma viruses. And if you're immune suppressed, if you've got chronic irritation going on, so your body's weakened by that, human papilloma virus is going to think with great glee that you've provided a great home for it. We'll also remember that around the world, every single sexually active person, around 70 to 80% of sexually active people, and including some who are not sexually active, will be infected with human papillomavirus at one stage or another during their lifetime. And the most typical times are onset of first sexual activity, and then we have a jump to major divorce age, 35 to 45. And then, believe it or not, we have a major jump to the age group where, unfortunately, long-term marriage spouses are passing away. So we've got people who are moving on with their lives and are lucky enough to find another loving partner. So we're talking about people getting HPV 75 plus years of age. Having multiple sexual partners is obviously a risk factor for anything, but it only takes one person, one act of sex with a male and a female to get pregnant, and it's the same as you only have sex with one person to get gonorrhea. So multiple sexual partners is basically just exaggerating your risk of opening yourself up to being exposed to someone who may have had human papillomavirus, or indeed has, because we now know it may lay dormant for a long time. Having receptive anal intercourse is not a prerequisite risk factor for getting anal cancer or rectal cancer. And it increases the risk only because there's probably irritation there, etc. So again, human papillomavirus love to get into those weakened cell tissues and find their home there. Smoking cigarettes, well, smoking cigarettes is a factor with any cancer. So you know what, if you can stay away from it, stay away. As we've said before, and we will keep on saying this again and again, some people may have no risk factors at all and will still develop anal cancer. And this type of anal cancer is rising most significantly among the heterosexual HIV negative women. But I have to say the vast majority of HIV negative heterosexual women do have a long history. They may have had it when they were in their 20s, maybe in their 30s, and now they're in their 40s or 50s or 60s of cervical dysplasia. So you've all heard about cervical cancer, and you've all heard about cervical dysplasia. That's why everyone goes for cervical screening with their PAP. Well, 100% of cervical dysplasia is HPV. End of story. That's the way it is. And there's also a correlation between cervical adenocarcinoma and human papillomavirus now. So, this human papillomavirus has just got its ability to affect many things. And so a history of a human papillomavirus-related anogenital disease, whether you have cervical dysplasia, with or without genital warts. Everyone seems to think, oh my gosh, HPV means I have genital warts. No, actually. You can have genital warts, which are a benign human papillomavirus strain, and not have any dysplasia whatsoever. And then there's people who have zero genital warts, anogenital warts, and they have dysplasia and they have the cancer. So I think that probably everyone with an anal cancer may have had a dysplasia in the past, but you wouldn't know. But anyway, this is all part of the screening. So there are other, in the same way that there's really rare colorectal cancers, there's really rare anal cancers as well. Adenocarcinoma, melanoma, lymphoma, neuroendocrine, sarcoma. And I know some of you will think, how the hell do you get anal melanoma where the sun don't shine? But you'll be amazed how many different cell types there are at that anal rectal dentate line where the cells change. And also huge lymph network around the anus, because of course it's one of the open sites, same as your mouth, same as your anus. It's your body's opening to the outside world. So the lymph system around there is just prolific and profound. And also in that same breath, because the mouth is the opening to the environment, the anus is, where are the two most sensitive parts of your anatomy? Your lips and your anus. So this is why anal cancer can be an extremely painful cancer to have and be treated for. So we're going to talk about that as well. These are the data for the colorectal cancers in Canada. So again, stats are only updated they're always archival. So it's 2017, 26,800. But we also know that colorectal cancer is one of the largest cancer killers over a global thing. So why that is, why we're getting more people, it's always interesting to find out those things. Colorectal cancer affects men and women almost equally. And screening rates are very low despite provincial screening programs. And the thing I have to say about colorectal cancer, and especially rectal cancer, is we're seeing such a massive increase in the amount of young rectal cancer patients. And when I say young, I'm talking 35 years old plus, some even younger. They typically have the genetic family history. But, you know, if you're 35 years old, you've got bleeding from your bum and you've got bloated abdomen and all the rest of it, get yourself to the doctor and do not be fobbed off. Do not be fobbed off with, oh, it's your age, you've got IBS, you're stressed. Don't allow that to happen because too many mistakes are being made by that fobbing off taking place. Anal cancer in Canada. Anal cancer is a rare disease worldwide. There's approximately 1,000 cases in Canada in 2015, maybe slightly more now. Anal cancer numbers are high amongst the men having sex with men and the HIV positive population. So we've already touched on why anyone who's immune suppressed is going to have more incidence of HPV related disease. And this is specifically the squamous cell carcinomas. However, as I've already said, we're getting a steady, scary climb in the number of heterosexual HIV negative population, especially for women over 40. And I also want to reiterate that we've got people in our support groups who are 35 years old being diagnosed with stage 1, 2 squamous cell anal carcinoma. Typically, we're thinking that the anal squamous cell carcinoma is reasonably slow growing, but, you know, maybe it's not. And it's also in a very delicate place for it to be because it's so close to so many other organs, the bladder, the uterus, you name it. So the spread can be really fast once it gets a hold. So again, any queries you have with your book, please get yourself to the doctor. Treatment options are surgery, chemotherapy, radiation, and then the biologic. So I am not going to go in depth into this. You're always going to talk to your doctor to understand the risks and benefits of any treatment. And it is always your decision what treatment you choose to go and do. But please make sure that you've read the pros and cons of everything and do not make decisions lightly, especially about not getting treatment. Okay? So surgery remains the primary treatment for the colorectal cancers and may well be an option for anal cancers. So in the very early stages, surgeries can involve the removal of a polyp during a colonoscopy, or in the case of anal cancer, a small lesion, if surgical removal will not impair the sphincter function. And in advanced surgeries, such as a colectomy, a section of the colon or rectum can be removed. And in the case of anal cancer, advanced surgery includes the removal of the lower part of the rectum and anus. Now, for the people who are having to have that kind of surgery done, they will have a colostomy. So if your anus and rectum is removed, you will have a colostomy. So that means you have a stoma. But as we say again and again, better with a bag than in one. Okay? You will learn to adapt to your stoma. That your life is worth living with a bag. We have a big problem with people not wanting to have surgery because they're more afraid of living with a bag than living at all. So it's very unusual. And if possible, when they do the surgery, especially with the colon and or the rectum, then what's left after a little space of time, they'll either reconnect it at surgery to create a functioning colon or the stoma, and then you can have a temporary stoma. So once your body's had a bit of time to relax, then they'll put your colon rectum back together again. This isn't usually the case for the anal cancer crew. Some of them may have a temporary colostomy provided just because the treatment itself can be brutal. And especially if the tumor is big, they may want to do a diverting stoma just so you don't need to poop through your anal canal. Chemotherapy and radiation. Now, I know that everyone is hoping that their medical oncologists are going to put them straight into biologics and immunotherapy because that's all the buzzwords of the news today. What I am going to say is the chemotherapy and the radiation treatment, yes, they keep on improving, but sometimes the oldie and the goodies are working. So I had a very old protocol for my anal cancer. It was called the Negro Protocol. I think my chemotherapy and radiation treatment was thought about in the 70s. Radiation treatment itself has advanced, but the chemotherapies I were on were ancient. And you know what? It worked for me. So don't be fazed by thinking, oh, well, they're just putting me in conventional chemotherapy and radiation. So how does chemotherapy work? So it stops the growth of cancer cells, either by destroying them or stopping them from dividing. And it may also be used to reduce the size of metastasis. Chemotherapy is given usually through the bloodstream, through a vein, or it may be administered orally. Radiation therapy, that damages the genetic material within the cancer cells and it limits their ability to divide. So normal cells, as we know, are also affected by chemoradiation, but they're able to repair themselves in a way cancer cells can't. But it still affects them, which is why you get hair loss for some cancer treatments. You don't always get hair loss for anal cancer treatment, but you know the colorectal crew typically lose the hair. You know, they get GI issues, their mouth hurts and all the rest of it, and they get diarrhea and all those things. But again, your medical oncologist is going to be your new best friend, and hopefully is going to be your new best friend. If you don't like them, get a second opinion. Okay, I'm going to say that here and now. You've got to like your medical team. You've got to trust your medical team. You've got to understand your medical team. If you're not a fit for them and they're not a fit for you, get another fit. Okay, that's most important. So the biologics that we've talked about, buzzword, unless you're living on Mars, you're not hearing about immunotherapy, biological therapy. And these are all the personalized treatments. And as you can read on that screen, that's a sort of basic thing about what they're doing, but the actual cutting edge technology of this is absolutely phenomenal. I mean, wow, every week you're getting new things. So it's an exciting time for medical treatments here in 2019. And I have to say, Ottawa itself here in Canada, we have amazing research going on here at both the Ottawa Hospital and the Children's Hospital of Eastern Ontario. Global impact on cancer treatment, it's phenomenal. So your medical oncologist will talk to you about those as well. But I have to say, most people having these kind of treatments have already, the conventional treatments have failed them. It's not that you have failed conventional treatment, it's conventional treatment has failed you. So that's when you start putting on clinical trials for biologics and personalized medicine, et cetera, et cetera. Pelvic radiation is a integral part of anal cancer and rectal cancer treatment. It's highly effective, huge improvements in radiotherapy techniques. It's 2019 now. If you had radiation or you knew someone who had radiation back in 1960, 1980, 1990, 2000, even 2010, we're years ahead again now. So don't let family tales of revolting radiation affect how you feel now, because everything is advancing stunningly. The actual chemotherapy for anal cancer is actually an exacerbator of the radiation effect, so it helps it along. So radiotherapy can affect tissues and other organs in the pelvic region, and because the radiation itself is a really long-term thing, you can live with the radiation effects which change and continue decades after your radiation treatment. And because we know that so many cancer patients are now having healthy, successful lives post-cancer treatment, we're now having to deal more with how that cancer treatment is actually affecting them in the short, medium, and long term. So again, don't be fazed if you get wacko symptoms a couple of years after your treatment. There's a load of information out there. Go and see your doctor. So sexual function issues. Again, I know so many of you feel embarrassed about this and you don't go and see the doctor, but please, sexual function, pelvic radiation can affect your sexual function. Vaginal stenosis, which means scarring of the vagina, it makes it tighter, sometimes too tight, you can't even get a finger in, let alone an erect penis in it. And for the men, erectile dysfunction, especially if they've had an APR. So if they've got a colostomy, then sometimes the surgeons all the colorectal surgeons try their damnedest to make sure that they are doing the best they possibly can to protect or the function, but sometimes life happens and it can't be helped. So please go and speak to doctors about it. Anal stenosis, same as vaginal stenosis. You know what? It seizes up, it goes smaller and smaller. Well, if you get anal stenosis, then that affects how you're going to poop. So when your poo's coming out, either before you've had a cancer diagnosis, it looks as thin as a pencil or it's ribbon-shaped, then get to the doctor because something's going on there. And then after you've had the treatment, it comes out pencil-shaped and ribbon-shaped because, you know, hey, the radiation itself may have had that issue, but you're still going to go and check with your doctor just to make sure it's the radiation that's done it and nothing else. You get bladder issues. We get joint pain, especially in the lower back, hips, and the upper thighs. We get rectal anal bleeding because of radiation proctitis. You have to learn your new normal. And if you know, this is why I want you guys to start looking in the toilet now. What does my poo look now I think I'm healthy? Okay? So now I'm healthy, as far as I'm concerned. My poo looks like this. I go to the toilet once or twice a day, or I go once every 2 days, or I go once every 3 days, or I go once a week. People have their normal. What is your normal? What does your normal look like? What does your normal feel like? And then when you start seeing changes in that, then you know to get to the doctor. Another big thing about pelvic radiation for anal cancer and the rectal cancers and any of the pelvic diseases is loss of fertility in women. And again, this is something your doctors are going to talk to you about, but be prepared, especially as we're seeing younger and younger women with rectal and or anal cancers in their 30s. So there's ways and means that your medical teams can help you here. Preventing colorectal and anal cancer. I'm going to say right now that, you know what, everyone can do every single prevention thing in the entire world. And you know what? You may still end up with cancer. Cancer is so complex a disease that we may think we know how to stop it, and we do our best to stop it, but it may not stop it. But all you can do is your best. So on this bit, we're going to talk about screening, healthy lifestyle, the human papillomavirus vaccination, and then the benefits of peer-to-peer anal cancer patient support. And I'm going to say there's huge support out there for colorectal as well. And from an emotional point of view, it's huge. And your emotional health is a massive part of your cancer healing. I'll tell you that as well. It is huge. So, colorectal cancer screening, average risk person. So, recommend that the average risk person start screening for colorectal cancer at the age of 50 through the use of the fecal occult blood test or the fecal immunohistochemical test, FIT, at least once every 2 years. So this is the stuff you get through the mail once you're over 50. The immunohistochemical one is way more sensitive than the old occult blood one. So we are rolling that in. I think Quebec's had the FIT for a while. Ontario's rolling it in. But they're good because sometimes you can have a poo that looks normal in your eyes because it just looks its usual brownie colors, because sometimes the actual blood content isn't enough to demonstrate itself in the color. But what this test does is it actually picks that occult bloods up. So occult means hidden. So it picks it up, and then at least your doctors know that there's something potentially going on. Where are you bleeding from is the question. So, you know, you may have polyps. We know that everyone with colorectal polyps does not go on to have colorectal cancer, but we know that every colorectal cancer came from a polyp at one stage. So it's one of those things. High-risk person is those of you out there who have a family history of colorectal cancer in a first-degree relative, parent, sibling, or child, or you are someone who is symptomatic. So symptomatic is going to mean you're bleeding, you've got discomfort, your poo's looking different. You just know inherently within yourself that something is wrong, okay? So high-risk people will start diagnostic screening for colorectal cancer through a colonoscopy once you become symptomatic or 10 years prior to when your first-degree relative was diagnosed. So if you had an aunt who died of colorectal cancer age 55, you know what? She had that colorectal cancer probably from the age of 50, truth be not told, because it's a slow grower as a rule. you're going for your colonoscopies at 45 or younger. And if you have any concerns, you go to your doctor and you ask for one earlier. Everyone freaks about the thought of a colonoscopy. They're embarrassed. You think it's going to really hurt. You know what? It's worth it. You're sedated. So it's good. As far as anal cancer screening is concerned, there are no national guidelines for general population anal cancer screening. And at present, internationally, anal cancer screening is mainly for our high-risk population. So we're talking about our immune suppressed. We're talking about our organ transplant recipients, our HIV positives, our men having sex with men, or past anal cancer patients. And what I want to add on there is high risk is if you've had a history of cervical dysplasia, CIN1, CIN2, CIN3, and obviously cervical cancer, or any of the vaginal and or vulval, penile, perianal cancers. You're a high risk. So what does this screening include? So a digital anal rectal exam, so easy, simple, brilliant. Your family physician can do a digital anal rectal exam on you, your gynecologist, you name it, it's fine. I know loads of people, again, I'm embarrassed, it's going to hurt. You know what? You take a deep breath, you relax, and they use loads of lubrication. So it's fine. If you can poop out of it, rest assured you can get someone's index finger up there. They're very definite. Then we're talking about high resolution anoscopy and a colonoscopy. So high resolution anoscopy, I have to say, is predominantly for the high risk male homosexuals, the HIVs, previous anal histories, whatever. And a colonoscopy is, the thing with colonoscopy is we really need to see the anal canal, and the colonoscopy, sometimes the person doing the colonoscopy can be, patting you on the shoulder as they bypass the anal canal, and then they're watching the screen. So we need the exam to start right from the get-go, from your anal verge. Anal paps and HPV testing. Now, anal paps are not routine, and it may be difficult for you to get one, but you can all but ask. Your gynecologist can do it. Your urologist can do it. HPV testing, as we know, is becoming the norm now for women replacing a cervical pap test, because as I said early on in this webinar, 70 to 80% of the sexually active population are infected with HPV probably 1 to 3 times during their lifetime. If everyone who had HPV got cancer, the world would have been dead many, many, many centuries ago. Human papillomavirus has been around since the Roman times and before. There's Roman poetry about genital warts, so please don't think you're dealing with anything new here. The most people can eradicate their human papillomavirus infection within 2 to 3 years naturally. Their body naturally gets rid of it. For some people, our bodies just can't. So my family, for instance, we must have a genetic predisposition for not being able to eradicate HPV, because my siblings have all suffered as kids with hand and foot warts, genital warts with no dysplasia. It's just like, whoa, why can't our bodies get rid of HPV in the same way as everyone else can? And it'll be a genetic thing. And you know what? In another few years, they'll find out exactly why genetically some people are prone. But it's just the way it is, which is why another thing, not to be embarrassed. I mean, just because you've got an HPV-related disease, your neighbor was just lucky that they managed to eradicate the HPV on their own. That's all. It hasn't singled you out as being any lower or lesser than the person who isn't have an HPV disease. And this is also why the HPV vaccine, again, you've got to read the pros and cons. You talk to your medical teams about the human papillomavirus. Human papillomavirus causes various diseases: head and neck, penile, anal, cervical, vaginal, vulval, throat cancers, you name it. The vaccine may be obliterating that. So get the vaccine. Pre-sexual activity is best, but they'll now allow it up to the age of 26 and above that age for other certain factors. So ask about it. What have you got to lose other than your own life? That's not by taking the vaccine. That's by dying of a long and lingering human papillomavirus-related cancer death. So preventing colorectal anal cancers, healthy lifestyle tips. And as I keep reiterating, please be aware that there's sometimes no apparent reason for why people are getting colorectal anal cancer. Okay, so you can be the perfect marathon running, vegan-esque yogarite in the entire universe and still get it. So what you can try to do, maintain a healthy weight, engage in moderate exercise, have a healthy diet, and you can limit your alcohol and your red and or processed meat consumption. I personally am on more of a carnivore diet. I eat red meat all the time, so it's more the crap food. So keep off the processed and stop smoking if you can. And as with all things, you always talk to your doctor before engaging in physical activity, and again about HPV vaccines and things like that. The benefits of peer-to-peer support for colorectal anal cancer patients. Now, your medical team is going to be your number one support, okay? But in addition to them, the availability of support for cancer patients from other cancer patients who have had the same or almost the same cancer as you is so stunningly important, especially for rare and highly stigmatized cancers, such as anal cancer, vulval cancer, vaginal cancer, penile cancer. There's no wonder you don't hardly hear of these cancers because people are embarrassed about talking to them. Most anal cancer patients, some of them will tell you right from the get-go they've got anal cancer. But you know what? Others may not. They may say they've got colorectal cancer. And why is that? Because there's a stigma about it. But you know what? If you do have anal cancer or you do have rectal cancer and you're embarrassed about saying that, just tell everyone you just got colon cancer then. You just do whatever is best for you. And that goes along with getting peer-to-peer support. Some people want support right from the get-go. Some people want support when they're almost finishing treatment. Some people don't want support until a year or so after. And some people never want or need peer-to-peer support. So this is for you to analyze your own wants and needs. The vast majority of you have access to Google, and all of you can research as to how to get support for anal cancer, the colorectal cancers. But what this peer-to-peer support does is provide you a gamut of things, which includes emotional support. Huge, huge, huge. You need emotional support from someone who knows almost exactly what you're feeling. And then advice for dealing with the treatment side effects, both in the short and the long term, and information on clinical trials. That is a complex world, and you can enter into it and think, oh my goodness, how on earth am I meant to navigate this? Because I have no idea. But there's help out there, and there's people out there to help you. There are specific anal cancer support organizations, as well as colorectal anal cancer support, as well as purely colorectal. You can contact me for more information. You can find me on the website, and Facebook's another brilliant one for searching out these support groups. There's a lot of testimonials for peer-to-peer support. So I'm going to let you guys just have a read over those things whilst I chat. But I would say the most support is emotional, reassurance about side effects, short, medium, and long term. A lot of people feel as though I'm the only one who's having this wacko symptom. What the hell is this? Am I unusual? Am I strange? Should I go and see my doctor? I don't want to be classed as a hypochondriac, but I'm feeling this and I'm sensing this and I'm seeing that. So all of these support groups give you the capability of, putting that question out there to literally hundreds of patients who have been through the same treatment as you, similar cancer as you, if not exactly the same, and they'll support you and say, no, you're not weird. The UK, for instance, is huge on its pelvic radiation disease. It is so recognized, multiple papers, multiple research. You come to North America and it's like someone got left in the potting shed because it's no pelvic radiation, no, don't believe in that, no, we don't. But people are improving now. So, it's out there. And Google is at most of your fingertips, either at home, or you can go to school, or you can go to a library, and you can investigate these things. The rarer and rarer the actual cancers get, the more you need support, because you can feel so isolated. You feel isolated through stigma. You feel isolated through, well, who the hell has had this cancer? Nobody. And then you research, and then you find your little support group with all these people who've had it. Anal melanoma is uber rare. But you know what? We have several people who have anal melanoma. Now, the melanoma crew get treated as per having melanoma. So all the treatments are different depending on what you've got. Anal melanoma, anal adenocarcinoma, anal squamous carcinoma, anal neuroendocrine, anal lymphoma. It's all of those things. But there's many, many people out there who love the support. So as I say, you analyze your own wants and needs, but you can venture forth and, dip your toes in a support organization. If you don't like it, then don't like it. If you do like it, then help is there for you. Again, the embarrassment, the stigma. People like peer-to-peer support because it's important, because it's here. People can make us laugh. When you've been through the same treatment, we know more butt jokes, poop jokes, anus jokes than anyone on the universe. I'll tell you that right now. And we laugh because laughter is an excellent medicine. And you got to laugh or you just cry all the time. So we laugh, we support, we help, and there are so many brilliant support groups out there. Facebook, the support groups I'm in, Anal Cancer Chat. We're international, predominantly English speaking. Australia has them. The Macmillan nurses in England are absolutely brilliant. Oh my goodness, they have so many resources. They have a phenomenal support mechanism. So whichever country you're in, find out what your own country is providing to you. But then there's always international ones out there. And like I say, we're predominantly English speaking, but I'm sure there's any other language out there as well. So don't worry. And Google Translate is your new best friend, because you can ask about those things. March is Colorectal and Anal Cancer Awareness Month. So as I've reiterated, we're having a statistically significant increase in the numbers of diagnosed anal cancers. Yet it's still one of the least talked about and the most stigmatized of all cancers. So a couple of years ago, Claudia, Calvin, and myself, we wanted to have an Anal Cancer Awareness Day. So we went for it, and we approached every single international colorectal organization, et cetera, and we now have a recognized international Anal Cancer Awareness Day. And by this, we hope to be able to increase awareness, lessen stigma, and get more people to talk to their doctors about their butt concerns. Talk about it, break the silence, lose the stigma, and save more lives.